So, Caring for Patients with Gastrointestinal Cancers with Melanie N. Allard, and that's DNP, APRN, FNP-BC, AGAC-NP. And we're going to ask Dr. Allard about those letters in just a minute here. So there's a comprehensive bio there. Dr. Allard, welcome. We're really glad to have you here today.
Thank you. I'm glad to be here with you guys.
Let's see, we're going to do kind of a David Letterman style for anyone who's familiar with that intro with 5 top facts about you. And we're going to start with number 5, and that is, as a side hobby, you love to design and be crafty. Number 4 is that you were undecided on what to do, so you double majored in nursing as well as criminology minors, with minors in forensics and sociology, and unfortunately never found a career path utilizing that without steering away from healthcare. Maybe one day. Your dad was in the military, so you grew up in a very diverse, spending a large portion of your childhood in Okinawa, Japan. Sadly, you don't speak Japanese. Your husband and you love to travel, mainly to warm locations where you can scuba dive. Favorite places so far have been Honduras and Belize. And number 1, have 2 fur babies, a beagle and a dachshund. They always keep us entertained. Great to know all of that. And before we go further, let me ask you a little bit about your career trajectory. What led you into healthcare and to the point where you are now?
Yeah, my mom was a nurse, so I kind of always wanted to follow in her footsteps. And then kind of what pushed me to go back to grad school is I just wanted to know everything about everything. I kind of wanted to be the master in my field. So I'm a forever student. You had asked me earlier about my degree. So I graduated in 2020 with my doctor in nursing practice. I will always obtain or keep my registered nursing license. So that's what APRN is. I graduated from East Carolina in 2020 with my family nurse practitioner. And I'm projected to graduate in May from UNC with my adult gerontology acute care nurse practitioner certification. So.
That is great. Thank you so much.
Yeah.
I mentioned poll everywhere earlier. So we're going to, the question, this first one is a word cloud. What one word comes to mind when you hear the term gastrointestinal cancer? And let's go ahead and take a look and see what we've got here. All right, so we're looking for one word. And I'll see if any come through the portal. All right, and we are getting some coming in. I want to thank everyone who is responding to this. So, Dr. Allard, are these the sorts of responses that you would expect?
Yes.
Okay. So pain and painful being accentuated there.
Mm-hmm.
All right, and I'll turn it over to you. Just let me know when to advance the slides. Medical oncology, gastrointestinal focus.
Yeah, so my name is Melanie Allard. Like we said, I'm a family nurse practitioner. I work at UNC in the Division of Medical Oncology, and I work specifically with cancers of the gastrointestinal tract. I recently started here as of last April. Next slide. So today's objectives for today's lecture will be to review basic gastrointestinal or GI anatomy, discuss various GI cancers to include their workup and treatment, as well as differentiate between each disease type, specifically with signs and symptoms, statistics, and management. Unfortunately, for the sake of timing, we will not cover treatment side effects and management of those symptoms. Next slide. So this is a really great diagram. The GI tract is a series of hollow organs that are connected to each other from our mouth to our anus. The organs that make up your GI tract in the order that they are connected include your mouth, esophagus, stomach, small intestine, large intestine, appendix, and anus. They also include organs that aid in digestion. That includes your liver and gallbladder and pancreas. The function of your digestive system is to break down the food you eat, release their nutrients, and absorb those nutrients in the body. Next slide. There are many types of GI cancers throughout the gastrointestinal system, and among each GI organ, there are additional cancer types based on cell type and location within that organ. For the purposes of this presentation, we will provide a brief overview of esophageal, gastric, hepatobiliary, pancreas, colorectal, and anal cancers. Next slide. So, according to more recent studies, more than half of all GI cancers are caused by modifiable risk factors. Some modifiable risks that are specific to GI cancers include, but not are limited to, a diet high in salt, processed foods, red meat, smoked foods, heavy tobacco and alcohol use, untreated H. pylori infections, as well as untreated hepatitis B and C infections, sediment lifestyle leading to obesity, as well as poor follow-up for recommended screening, specifically colonoscopy screenings, which now starts at the age of 45. Next slide. So this is a list of diagnostics that is not specific to one specific GI cancer, but a synopsis of various studies or examinations that may be ordered if there is a concern for a GI malignancy. I will mention these studies and their significance to each disease diagnostic workup throughout the presentation. Next slide. I will briefly mention here biomarker testing. It is often collected as part of a patient's diagnostic workup and treatment plan development. Biomarker testing is for people who have cancer, which can include solid tumors and blood cancers. A biomarker is anything present in or produced by cancer cells or other cells of the body in response to cancer or certain benign or non-cancerous conditions that provides information about a cancer, such as how aggressive it is, whether it can be treated with a targeted therapy, or whether it is responding to treatment. Biomarker testing is a way to look for genes, proteins, and other substances, also called tumor markers, that can provide information about cancer. Each person's cancer has a unique pattern of biomarkers, and some biomarkers actually affect how certain cancer treatments work. Next slide. There are two main types of biomarkers and tumor markers: circulating tumor markers and tumor tissue markers. You do not need to know specifics of each. Just know that they are used to help aid in diagnosis, staging, disease response, as well as prognosis estimation. Next slide. This slide might be a little bit overwhelming. I did it mostly for those that are using it as a reference, but you do not need to know or memorize these. This is just a reference of the most common biomarkers / tumor markers used in GI cancers. Next slide. This is again just a reference slide. Next slide. So to keep it simple, cancer is treated with various methods, either together or individually. These modalities include surgery, radiation, systemic therapy, such as chemotherapy or immunotherapy, and or targeted procedural therapy, such as ablation or embolization. Next slide. So this is our first question. So what are some modifiable cancer reducing strategies? A, limit alcohol and tobacco intake. B, colonoscopy screening at the age of 45 and not wait until the age of 50. C, consume a diet high in fats and processed meats. Or D, treat H. pylori infection. Or E, A, B, and D. Good job. Next slide. So to keep it simple, chemotherapy treatment can be broken down into adjuvant, neoadjuvant, and palliative treatment. Neoadjuvant chemotherapy is additional cancer treatment given after primary treatment to lower the risk that the cancer will come back. The treatment modality is given after complete removal of the entire tumor to help reduce the risk for distant metastases with the goal to eradicate micrometastases or spread throughout the body. Neoadjuvant chemotherapy is given before local treatment to facilitate surgery with the goal to shrink the primary tumor as well as kill any micrometastases. And finally, palliative chemotherapy is given to those with metastatic or inoperable tumors with the goal of increased quality of life and prolonged survival. Surprisingly, many patients may actually have overall decreased symptom burden with chemotherapy than without it. Next slide. This is a nice little depiction of the three types of systemic treatment. Systemic therapy can be broken down into chemotherapy, targeted therapy, or immunotherapy. Chemotherapy targets rapidly dividing cells. These include cancer cells as well as non-cancerous cells that are found in the skin, hair, and intestines, for example. Cancer cells, unfortunately, are extremely smart and can become resistant over time. This poses challenges that are not if there are no other treatment options for the patient. Targeted therapy is specific to proteins that are required for cancer growth. Targeted therapy is commonly talked about as a treatment for patients who have certain abnormalities in their tumors that can be found through biomarker testing. Immunotherapy uses our immune system to fight against the cancer cells. This type of treatment is very individualized, and not everyone can receive this. Whether you may be a candidate for immunotherapy depends on specific type and stage of your cancer, biomarkers that your cancer expresses, and whether current cancer treatment guidelines and data support immunotherapy for certain situations. Next slide. These are just examples of various types of treatment we can use in GI cancers. They're easy to learn if you make note the endings of the drugs: platin, isen, mab, and ide. Next slide. So this is our question number 2. Which of the following is considered neoadjuvant chemotherapy? Chemotherapy that's administered prior to surgery or radiation in order to shrink the tumor. Chemotherapy that's administered after surgery or radiation therapy in order to destroy cancer cells. Chemotherapy administered with radiation in order to help radiation work better. Or chemotherapy administered in order to prevent cancer cells from spreading. Good job. That would be neoadjuvant. Next slide. So these are the most commonly used regimens in GI cancer treatment, and these include 3 main treatment options: FOLFIRINOX, FOLFOX, and FOLFIRI. The main chemotherapies in these regimens include 5-FU, irinotecan, oxaliplatin, and a folinic acid called leucovorin that helps the 5-FU bind to an enzyme inside the cancer cell. FOLFIRINOX is a more intense regimen than either FOLFOX or FOLFIRI. Although it has a higher level of treatment response, it also has more severe side effects than either FOLFOX or FOLFIRI. Given that each of these regimens includes a chemotherapy called 5-FU, it's important to note that with this drug, the patient will need a pump for 46 hours and requires a family member to aid and disconnect. It's imperative when evaluating whether a patient would be a good candidate for one of these regimens to also think of comorbidities, patient resources, educational level, and family support. Additionally, symptom management is crucial in all 3 regimens. Next slide. Question number 3, how is systemic chemotherapy used? A, chemotherapy can be used as the only cancer treatment for either cure or palliative. B, chemotherapy can be used prior to or after surgery. Or C, chemotherapy can be used with or without radiation therapy, targeted therapy, or immunotherapy. Or D, all of the above. Good job. All of the above. Next slide. And this is our last Poll Everywhere question. What are some things to consider specific for a patient going home with an infusion pump? Patient support system, health literacy, patient's interests such as swimming or taking a bath, or all of the above? D, that is correct. Because that pump stays on for 46 hours, all of these are of considerations. Okay, next slide. Now we'll dive into the various cancer treatments and the cancer types. So first we'll talk about esophageal cancer. The esophagus is a muscular tube that begins at the continuation of the pharynx in the neck and ends at the junction with the stomach. Its job is to aid in transportation of food and fluids from the oral cavity to the stomach through the thoracic cavity and passes through the diaphragmatic hiatus into the abdomen. Next slide. There are 2 main esophageal cancer types that I will discuss today: adenocarcinoma and squamous cell carcinoma. The distinction is important when discussing the pathology and risk factors for the disease as it dictates the treatment and the workup. Adenocarcinoma starts in the gland cells. It's usually found at the distal end of the esophagus. The most common type of cancer of the esophagus among whites, and it's more common than squamous cell carcinoma. Squamous cell carcinoma starts in flat, thin lines that line the surface of the esophagus. It's usually found in the middle or top part of the esophagus, and it's more common in African Americans. Next slide. Cancer of the esophagus is a worldwide health problem due to poor prognosis and relatively high incidence in many parts of the world. It's relatively rare, though, in the United States. It only accounts for 1% of all cancers in the U.S. and occurs in men more than women. And the risk increases with age. Whites are more likely to develop esophageal cancer at higher rates than Black men in all age groups. Advances in surgical techniques, treatment options, and radiation therapy have not improved prognosis substantially. Next slide. Adenocarcinoma has been directly related to GERD, specifically in individuals with reported weekly symptoms, as well as obesity, older age, 50 to 60s, and predominantly male sex. Squamous cell carcinoma has a higher rate in those who partake in heavy alcohol and tobacco use. In addition, if they've underwent prior radiation to the thorax for another malignancy, and it's more common in those 60 to 70 years old. In addition, a diet high in starch foods with or without fruits and vegetables also increases one risk. Next slide. Patients often present with a cluster of symptoms with difficulty swallowing, either progression or acute, painful swallowing, weight loss, heartburn, regurgitation, hoarseness, which can be a late finding, vomiting up blood, persistent cough, as well as pain between the shoulder blades. They may also report abdominal or chest pain, especially in the setting of metastatic disease or larger tumors. Next slide. Diagnostic workup is most often made on endoscopy, possibly incidentally if the patient has a history of Barrett's esophagus or ongoing GERD. The tumor can also be identified through patient-reported symptoms of dysphagia or difficulty swallowing that prompt EGD. Other imaging studies that may include CT scan of the chest and abdomen with contrast to determine the size of the tumor and if metastatic disease is present. Guidelines currently recommend a PET scan if no metastatic disease is present on CT scan. If the tumor is too small, it may not be seen on the other modalities. Barium swallow studies are clinically indicated in those having difficulty swallowing or if there is a concern for aspiration. Some lab work that is used in diagnostic workup for most of the GI cancers include CBC, a comprehensive metabolic panel, liver enzymes, as well as nutrition-based studies such as prevalbumin. Physical examination also involves a thorough head-to-toe assessment. Any palpable lymph node may be a sign of metastatic disease, especially if it's found in the left supraclavicular fossa. And then endoscopic ultrasound is performed in patients with non-metastatic disease because it can assess the depth of the tumor and then any pathologic lymph nodes. Next slide. Treatment for esophageal cancer includes a variety of modalities depending on the tumor's location, stage, and histology, as well as the patient's comorbidities. Chemotherapy, radiation therapy, and surgeries are mainstays, but immunotherapy may also play a role in treatment pending the patient's biomarker results. The most common treatment for esophageal cancer is neoadjuvant chemoradiation, followed by surgery, and then adjuvant chemo. Next slide. Management of these patients should be specific to ongoing management of the following. So they may have difficulty swallowing or painful swallowing, which may warrant an esophageal stent placement. They may have malnutrition and weight loss requiring placement of a gastrostomy tube, as well as internal feeds and a referral to nutrition and dietary for recommendations. Chest pain, pressure, or burning, which could be from the tumor itself or reflux. They may warrant other prescription medications such as proton pump inhibitors or histamine blockers. And it's important to note anyone with chest pain to always rule out cardiac origin as well, even if they have an oncology diagnosis. Next slide. Overall, the prognosis for esophageal cancer remains poor despite new advances. The majority of patients that present with metastatic disease in which cure is not possible or achievable. These survival rates do not separate squamous cell carcinomas from adenocarcinomas, although people with adenocarcinomas are generally thought to have a slightly better prognosis overall. Next slide. Some prevention strategies for esophageal cancer includes GERD treatment and prevention, tobacco and alcohol abstinence. There's some new studies that show that aspirin or nonsteroidal anti-inflammatories are related to decrease in esophageal cancer, although this is not proven. Obesity prevention, but overall, unfortunately, there are no current screening guidelines in place. Next slide. Excuse me. Next, we will talk about gastric cancer or stomach cancer, which is a growth of cells that starts in the stomach. The stomach is in the upper middle part of the belly, just below the ribs. The stomach helps to break down and digest food. Stomach cancer can happen in any part of the stomach. In the United States, stomach cancer is more likely to start at the gastroesophageal junction or the GE junction. This is the part where the esophagus meets the stomach. Next slide. Gastric cancers are predominantly categorized by site of occurrence, GE junction, proximal stomach, and distal stomach. Then the cancer type is broken down by pathology or cell type. Roughly 95% of all gastric cancers are adenocarcinomas. Adenocarcinomas are cells that line glands and produce mucus. They mostly affect older people with an average age at diagnosis of 68. Another common type that we treat among our group is gastrointestinal stromal tumors, or GIST. They can occur anywhere in the GI tract, although it is most common in the stomach, which account for about 60%. This is most common in 50 and older. Next slide. Despite its worldwide decline in the past century, gastric cancer remains a major source of cancer deaths around the globe. About 26,000 new cases of stomach cancer a year, affecting men more than women. Gastric cancer is more prevalent in individuals who identify as Hispanic, Asian Pacific Islander, and African American than in non-Hispanic whites. Gastric cancer is more common in older adults and frequently diagnosed between ages 65 and 74. Next slide. For most of the early 20th century, gastric cancer was the leading cause of cancer death in the U.S. It is now approximately the 15th leading cause of cancer death in the U.S. There's two possible reasons for this. Increased use of refrigeration for food storage has led to people eating fewer salted and smoked foods. And there's been a decline in people infected with H. pylori, which is thought to be a major cause of gastric cancer. Next slide. Excuse me. Risk factors associated with gastric cancer are multifactorial and include those that contribute to chronic gastritis, atrophy, and inflammation, such as chronic H. pylori infection, pernicious anemia, diets high in salt and salt-preserved foods. Other factors include obesity, smoking, prior gastric surgery, prior abdominal radiation, male sex, as well as inherited genetic mutations. Next slide. Gastric cancer can go undetected because patients often are asymptomatic. Therefore, it typically is discovered incidentally on endoscopy for evaluation of other issues. Gastric cancer can have a varied presentation and often have no outward physical exam findings until the disease has become at least locally advanced. Most often, patients present with symptoms that are vague and often overlooked, as they can be attributed to other issues such as GERD. Additional clinical signs and symptoms of gastric cancer include, but are not limited to, unintentional weight loss, tumor-related anorexia, nausea, persistent vague epigastric abdominal pain, early satiety or feeling full after a small meal, persistent heartburn and indigestion, as well as difficulty swallowing. This is most common with proximal tumors. Jaundice or yellowing of the skin may reveal metastasis or spread to the liver. Next slide. Diagnostic evaluation of suspected gastric cancer should include a complete history and physical examination. Focused areas of the physical examination should include unintentional weight loss and heart rate. Tachycardia is often suggestive of dehydration, secondary to poor oral intake. Pale membranes are also suggestive of anemia. A tumor marker or CEA level can be used to detect tumor metastasis and is associated with gastric cancer prognosis. An EGD is often performed for tissue diagnosis and anatomic location of primary tumor. And then an endoscopic ultrasound or EUS should be performed to determine tumor stage and nodal status in the absence of radiographic evidence of distant metastatic disease. It's also important to note in most of these patients, they will also get further imaging such as a CAT scan of the chest, abdomen, and pelvis. Next slide. After tissue diagnosis and staging evaluation, guidelines recommend treatment based on clinical stage and tumor type. I will not go into great detail, just know that if there is metastatic disease, systemic therapy with palliative intent or clinical trial is usually the only option. If no metastatic spread is present, patients will receive chemoradiation in the peri-op period, followed by gastric resection with removal of the surrounding lymph nodes. Next slide. Prognosis continues to improve and has improved over the past couple of decades, secondary to advances in surgical treatment, post-op care, and multimodality therapy. The high mortality rate reflects the prevalence of advanced disease at presentation and relatively aggressive biology. Overall, in the United States, the 5-year survival rate is about 70% in stomach cancer if it's localized and 93% in GIST if localized. If it's regional and then distant, you will see survival rates quickly decline. Next slide. Patients with extensive atrophic or metaplastic changes in the gastric mucosa are at an increased risk for gastric cancers. Screenings should be limited to individuals found to be at high risk for gastric cancers, including those with a genetic predisposition, history of H. pylori infection, diagnostic dysplasia such as Barrett's esophagus. But in summary, gastric adenocarcinoma remains a significant world health issue with ongoing poor outcomes. However, neoadjuvant therapy and immunotherapy continue to offer promising results. Next slide. Next, we will talk about hepatobiliary cancer. For the purposes of this presentation, we will stick to 3 types of hepatobiliary cancers: liver, hepatocellular carcinoma, bile duct cancers, and gallbladder. Next slide. The liver is the largest internal organ, lying under the right ribs just beneath the right lung. It is divided into right and left lobes. Biliary tract cancers are rare, but comprise intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancers. Next slide. Incidence and mortality rates for cancer overall are declining, but rates for HCC or hepatocellular carcinoma are increasing. Primary liver cancer is the leading cause of cancer deaths worldwide, accounting for more than 700,000 deaths per year. More common in sub-Saharan Africa and Southeast Asia, more common in men more than women. And liver cancer incidence rates have more than tripled since 1980, while the death rates have more than doubled during this time. Next slide. Bile duct cancer, cholangiocarcinoma, on the other hand, is very rare. It's more common in Southeast Asia due to parasitic infection that causes this type of cancer. It can occur in younger ages, but mainly seen in older people, with the average age for 70 for intrahepatic and 72 for extrahepatic. Gallbladder cancer is more common in women than men. It is not usually found until advanced stages, or they have ongoing right upper quadrant discomfort and pain. And 1 out of 5 are found at early stages. That's really low. Next slide. This is a nice reference that depicts the stages of liver disease and progression to hepatocellular carcinoma. Cirrhosis is usually the result of repeated injury and inflammation and can be caused by several different diseases and conditions. If the cause of the liver injury is reduced or eliminated, it is possible for the liver to slowly repair itself and recover. If it's not able to repair itself, it can progress into hepatocellular carcinoma. Next slide. The most important risk factors for HCC in the U.S. are chronic infection with hepatitis B and hepatitis C virus, heavy alcohol consumption, obesity, diabetes, and tobacco smoking. Other non-modifiable risk factors for all these cancers include race and ethnicity, gender, age, primary biliary cirrhosis, which is a type of autoimmune disease, as well as certain inherited liver diseases. Next slide. Because most patients with liver cancer have chronic viral infections, such as hepatitis B and C, routine imaging is performed for early detection of HCC with ultrasound and AFP tumor markers every 6 months. Many people at time of diagnosis are asymptomatic, but as time goes on, they may have reports of fatigue, malaise, jaundice, loss of appetite, weight loss, abdominal pain, specifically in that right upper quadrant, as well as notable increased abdominal girth due to ascites or fluid, and as well as jaundice or yellowing of the skin. Next slide. Bile duct cancer or cholangiocarcinoma may present with jaundice, dark urine, pruritus or itching, weight loss, as well as clay-colored stools. They may have, again, abdominal pain, loss of appetite, as well as potentially a fever. Next slide. Gallbladder cancer is often diagnosed at an advanced age, with 65% of patients over the age of 65. Many do not exhibit any symptoms until it's advanced. Symptoms often tend to be vague and often delaying time to diagnosis. Most patients are diagnosed after an elective cholecystectomy with confirmed pathology. The most common symptoms are persistent right upper quadrant pain, nausea or vomiting, jaundice, weight loss, bloating, as well as a sudden, rapid, intense pain in the right upper quadrant that may radiate to the shoulder blades. Next slide. The Diagnosis of biliary tract cancer can be challenging because of the anatomic location and late presentation. For initial workup, a complete abdominal ultrasound or CT is usually preferred. These usually can display the extent of biliary obstruction and to evaluate for conditions such as gallstones. Usually if gallstones are present, a surgical referral is placed and usually they undergo a cholecystectomy. However, if there's a high suspicion for cancer, a CT of the chest, abdomen, and pelvis with IV contrast is recommended to evaluate for distant metastasis, as well as vascular invasion. MRCPs are also used to detect bile duct or vascular invasion. And currently the role of PET-CT is still controversial and is only used in cases where there's high suspicion of metastasis, but it wasn't seen on prior CT scans. I've included further lab work to check. And then for this, a tumor marker, such as a CA19-9, is related to biliary tract cancer. It's important to note that not all patients express an elevation in this biomarker and should not be used as a sole diagnostic tool. Next slide. Standard treatment options for adult patients with HCC that are low grade include surgical resection, liver transplant, and ablation. Ablation is a treatment option that destroys liver tumors without removing them. These techniques can be used in patients with few or small tumors and when surgery is not a good option, often because of poor health or reduced liver function. Those with advanced disease, systemic therapy with chemotherapy with or without immunotherapy is recommended. Next slide. With gallbladder or bile duct cancers, surgery is the only potentially curative modality, but most patients are asymptomatic until advanced stages and therefore present with locally advanced or metastatic disease. Patients will often be offered surgical resection, which represents the only treatment associated with a long-term survival. Achieving a tumor-free surgical margin is the only robust prognostic indicator and is a primary goal of resection in these tumors. Regarding systemic therapy, advances in the treatment of biliary tract cancer is still rare, but there are options. Next slide. Prognosis of gallbladder cancer is poor because of its aggressive tumor biology, late presentation, complicated anatomic position, and advanced stage of diagnosis. Next slide. Some prevention strategies include prevention of sexually transmitted infections such as hepatitis, remaining up to date on your hepatitis vaccinations, avoidance of excessive alcohol and tobacco use. In those with known hepatitis, early treatment will lower the chances of cirrhosis, as well as lower the chance of neoplasm development. Next slide. Next, we will talk about pancreatic cancer. Pancreatic cancer, also called exocrine cancer, is a disease in which malignant cells are found in the tissues of the pancreas. The pancreas is located behind the stomach in the upper left abdomen. It is surrounded by other organs, including the small intestines, liver, and spleen. The pancreas has exocrine and endocrine functions. The exocrine function is responsible for digestion, and the endocrine function regulates blood sugar. Next slide. Pancreatic cancer is divided into malignant and borderline malignant histology. For the purpose of this presentation, we will discuss the two most common that we currently treat: pancreatic adenocarcinoma and pancreatic neuroendocrine tumors. Adenocarcinomas account for 95% of the cancers of the exocrine pancreas. This type of cancer occurs in the lining of the ducts of the pancreas, but it's also possible for adenocarcinoma to develop in the cells that create pancreatic enzymes and help your food digest. At the time of diagnosis, this is often advanced stage. Pancreatic neuroendocrine tumors are tumors that form in the islet cells. These are hormone-making cells that affect body functions, including controlling the amount of glucose in the blood and helping digest food in the stomach. These tumors may be benign or malignant, but they're often less common, but they have a pretty good prognosis. Next slide. Despite the high mortality rate associated with pancreatic cancer, its etiology is poorly understood, leading to continued high mortality. However, more than 90% of pancreatic adenocarcinomas are driven by early activation of the genetic mutation, also known as KRAS mutation. In general, pancreatic cancer is slightly more prevalent in men than women, slightly more common in individuals who identify as African American than white, accounts for 3% of all cancers in the US and 7% of all cancer deaths, and the risk of developing pancreatic cancer increases with age, with the average age at time of diagnosis being 70. Next slide. Again, we discussed this briefly previously with all the other cancers, but pancreatic cancer is associated with modifiable risk factors in addition to non-modifiable risk factors such as genetic syndromes and predisposition. If you note, they have similar risk factors as the other cancers, so I won't go extensively into that. Next slide. Signs and symptoms of pancreatic cancer can be related to the location of the disease. The pancreas is divided into three main parts: the head, body, and the tail. Tumors in the head or the body can produce obstructive symptoms such as itching or pruritus, jaundice, and abdominal pain. This results in light-colored stools and dark urine due to the lack of bilirubin. Tumors in the head of the pancreas tend to be detected earlier in the course because of its obvious signs of jaundice. Patients with tumors at the tail of the pancreas will present with pain, either mid-epigastric, with or without radiation to the back or left upper quadrant, and these symptoms tend to present later in the disease. If the tumor is large enough, they may present with symptoms of pyloric or gastric outlet obstruction, with symptoms such as intractable nausea and vomiting, abdominal distension, and significant weight loss. Next slide. When suspicion of pancreatic cancer with or without signs of obstructive jaundice exists, a complete abdominal ultrasound or CT scan of the abdomen and pelvis is performed, in addition to full staging imaging to rule out metastasis, including a CT chest. MRI and CT appear to have approximately equivalent accuracy in assessing local involvement of a pancreatic lesion. Although MRI may be better at determining metastasis, CT scan has advances such as lower cost and greater availability. PET scan and the workup of pancreatic cancer is still being investigated. An endoscopic ultrasound, or an EUS, is helpful in the detection of small lesions and for tissue sampling with fine needle aspiration for biopsy and pathology. Some blood work for further diagnostics includes a CBC, CMP, and liver function. Again, similar to hepatobiliary, a biomarker to trend is a CA19-9, but again, not all patients express this gene or biomarker. If a patient is a candidate for surgical resection, a diagnostic laparoscopy may be performed to ensure the absence of peritoneal disease. Common sites of pancreatic metastasis include liver, lung, and peritoneum. Next slide. At the time of diagnosis, most patients with pancreatic cancer already have metastatic disease, unfortunately. These patients would not benefit from the surgical removal of their primary tumor, so more often than not, the goal of treatment is palliative in nature with systemic therapy. Next slide. Prognosis is very poor but slowly improving with ongoing clinical trials for systemic therapies. Systemic therapy and treatment advances will hopefully help improve these low numbers depending on patient clinical characteristics. Next slide. Guidelines related to prevention of pancreatic cancer have not been established. The areas where prevention is addressed are in patients with confirmed genetic predispositions related to high-risk syndromes or mutations. In addition to addressing modifiable risk factors such as obesity, tobacco use, alcohol use, diabetic control, and diets high in processed meats and foods. Next slide. Next, we will talk about colorectal cancer. The colon is the longest part of the large intestine and is connected to the small intestine at one end and at the anus at the other end. The colon removes water and some nutrients, as well as electrolytes from partially digested food. The remaining material, solid waste called stool, moves through the colon, is stored in the rectum, and leaves the body through the anus. Next slide. The colon includes the ascending colon, cecum, transverse colon, descending colon, sigmoid colon, and rectum. The location of the tumor in the colorectum has therapeutic and prognostic significance. This critical distinction and diagnosis is needed to identify a proper interprofessional approach. Next slide. There are multiple types of colorectal cancers, but during this presentation, we're going to limit this presentation to the three cancer types listed above. Colorectal adenocarcinoma develops in the lining of the large intestine or at the end of the colon or rectum. They often start in the inner lining and spread to the other layers. FAP accounts for 1% of all cancers in the colon or rectum. People with this syndrome may develop hundreds or even thousands of colon or rectal polyps. These polyps tend to occur when people with this syndrome are about 10 to 12 years of age. And nearly all people with FAP develop colorectal cancer during their lifetime, And as a result, some people have their colon removed as a preventative measure. And then lastly, carcinoid tumors or neuroendocrine tumors develop in the nerve cells called neuroendocrine cells, which help regulate hormone production as previously mentioned. They're slow growing and may develop in the lungs or any part of the GI tract, and they account for about 1% of colorectal cancers. Next slide. These statistics are slightly older, but the American Cancer Society does not currently have 2022 projections. We do not know. What we do know is that colorectal cancer continues to represent significant morbidity and mortality globally. In the US, it is declining, and this is due to increased use of screening colonoscopies. Next slide. Risk factors for colorectal cancer are not always within a person's control, but some lifestyle factors help cut risk. Non-modifiable risk factors include those with a family history of colorectal cancer and individuals with history of chronic inflammatory disease. Modifiable choices can include quitting smoking, limiting a diet high in red and processed meats, limiting alcohol, as well as eating a low-fat, high-fiber diet and getting regular exercise. Next slide. Symptoms of colorectal cancer often do not show up until later stages of the disease. These symptoms include red streaks of blood in the stool, alternating bowel pattern with diarrhea or constipation, bloating, abdominal pain, dark or black stools. A feeling of needing to have a bowel movement when the bowel is empty could also signal colorectal cancer. And then unexplained weight loss and fatigue are common symptoms as well. Unfortunately, the delay from symptom onset to diagnosis is prolonged, sometimes ranging from weeks to years, up to 4 years in some of the studies. Next slide. Diagnostic evaluation includes a thorough family, medical, and physical assessment. Lab work, as previously mentioned. Biomarker testing in this one would be a CEA. And then imaging such as a CT chest, abdomen, or pelvis, or MRI to assess the extent of local disease and evaluate for the presence of distant disease. Tissue sample is used to establish a diagnosis, and it's often collected during the time of colonoscopy or surgically if they presented to the emergency room with a bowel perforation or obstruction. Next slide. So this is just a nice colorectal cancer staging. The earliest stage is 0. The late stage is 4. That means that it has spread. A higher number, such as stage 4, means cancer has spread. And then with each stage, an earlier letter means a lower stage. So next slide. This is a great slide. It just kind of breaks down treatment and disease management based on clinical staging of cancer. You can see that stages 0 to 2 is usually just surgery. And then when you go to stage 4, it's usually palliative surgery for symptom control. It's not curative. All right, next slide. In colorectal cancer, the degree of survival is dependent on the degree of treatment as well as the patient's biomarkers. For instance, patients are tested for what is called MSI status. For the purposes of this lecture, if a patient has MSI high, they have improved prognosis due to the likelihood their tumor will respond to other systemic modalities, such as immunotherapy. Other prognostic indicators include pathologic features, such as positive surgical margins or not, lymphovascular invasion, or poorly differentiated histology. Next slide. The biggest thing that take away from this slide is that the U.S. Preventative Services Task Force has updated its guidelines to begin colon cancer screening at the age of 45, not 50. Next slide. We kind of mentioned this already, but some prevention strategies is to remain up to date with colonoscopy screenings, keep a diet low in red meats and processed foods, diet high in fiber with enriched fruits and vegetables. There's new data to support a higher level of vitamin D, regular aspirin use, especially at 50 to 59 years old, and then regular exercise to prevent obesity is really important. Next slide. Lastly, we will talk about anal cancer. Next slide. Anal cancer represents a less common form of GI malignancy that arises from the epithelium of the anal canal. They are distinct from rectal cancer and anal skin cancer in that they originate from the epithelium between the anal rectal ridge and the anal verge. Next slide. The most common presenting symptom of anal cancer is rectal bleeding. Other symptoms may include rectal itching, mass at the anal opening, as well as pain, narrowing of stool, changes in bowel movements, abnormal discharge, or even swollen lymph nodes in the anal and groin region. It is not uncommon for patients and healthcare professionals to mistake these symptoms as benign conditions such as anal fissures or hemorrhoids, which may coexist, but without proper diagnosis, it delays treatment. Unfortunately, this delay is common and can delay symptoms to diagnosis 2 to sometimes 4 years, like previously discussed, with an average of 6 months. Next slide. Anal cancer is relatively uncommon malignancy, but despite the rarity of this, its incidence is increasing in the United States. The increased rates result from increased risk factors, specifically HPV. I've included the HPV strands that are most common. Other risk factors include immunocompromised conditions, which facilitates persistence of HPV infection, as well as smoking. Next slide. The diagnosis of anal cancer can be initially made with a thorough rectal examination with identification of an intraluminal mass. For painful lesions, it's often recommended to undergo this examination under anesthesia, and at the same time, you can get a biopsy to confirm diagnosis. Once diagnosis is confirmed, a CT, chest and abdomen, as well as MRI pelvis is completed. PET scan may offer additional sensitivity in identification of lymph node metastasis that may not be found on CT alone. Next slide. Treatment includes definitive chemoradiation is associated with improvement in 5-year overall survival rates, as well as reduced morbidity. However, in patients with persistent or locally recurrent and non-metastatic disease after completion of chemoradiation, it's called salvage resection with an abdominal peritoneum resection, an APR. And this surgery completely removes the distal colon, rectum, and anal sphincter complex using both anterior abdominal and perineal incisions. And this results in a permanent colostomy bag, but is associated with higher survival rates. Next slide. This is just a brief overview of this 5-year survival rate for the American Cancer Society. You can see that a 5-year survival rate for localized treatment is 82%. Next slide. And that concludes my presentation.
All right, Dr. Allard, thank you so much. This is incredibly informative. Let me go ahead and go to our Q&A slide there, and let me just bring up the moderation on that so I can pass through any questions that you may have. So there we go. So while we're waiting to see if questions come in from the audience, I just wanted to ask a general question. What are some of the most rewarding aspects for you of what you do? And then maybe what are some of the most challenging?
I think some of the most rewarding is truthfully getting to know our patients. We get to know them during the most intimate times, as well as one of the scariest times. And getting to know them and how they ended up here is really important, as well as educating them and their family members. It's really astonishing, the ones that have colon cancer and they have a spouse or a loved one that's with them that has yet to get a colonoscopy. So it's little things like that that you try to make an impact on. Yeah.
Thank you. Let's see, we have a question. How many GI patients need colostomy bags, and is it difficult for patients to deal with?
I do not know the exact percentage that need colostomy bags. Sometimes patients, if they do need one, it can be reversed surgically after the completion of chemotherapy, but that's a patient-to-patient specific case. And then as far as patients difficult to deal with, we often refer them to the ostomy nurse. There's at UNC, we do have a team, and they provide education. They provide support to make sure that they have adequate supplies and know how to manage it. But yes, it does come with a psychosocial aspect too that we need to address.
Gotcha. Thank you. We do have another question. Can you speak briefly about over-the-counter screening tests for colorectal cancer? Are they a good idea for those younger than 45 to use?
I do not know much of that. When I was at my last job in an outpatient GI setting, the primary care offices often used I don't know the name brands of the colorectal ones that they used, but the mail-in boxes, those detect small amounts of blood or trace blood in stool. It's often important to note, though, in those patients, if they have hemorrhoids, they could have, a false positive as well. But
Great. Well, thank you very much. Let me ask one, and I just actually was driving to the office today and heard yet another report on the radio talking about the increase in younger people contracting colorectal cancer. Do you have any thoughts on that?
So my group, I work mostly with, I do take care of colorectal patients at UNC, but Tammy Triglianos and Dr. Sanoff take care of a large percentage of the colorectal. But I will say when I was with them, there was a large amount of people, usually in their 20s and 30s. So my advice to them is if they're going to their physician and they don't seem to be heard, for especially if they have alternating bowel movements, abdominal pain, or blood in the stool, to try and get another opinion.
Great, thank you. And that actually leads nicely into this next question. Do you work with MD oncologists or treat patients independently? And then maybe kind of as a follow-up to that, what does the multidisciplinary team look like?
Yeah, so I do work with 3 current oncologists at UNC, Dr. Sanoff, Dr. Soma, and Dr. Sora. Tammy mostly works with Dr. Sanoff, and I work with Dr. Sora and Dr. Soma. I do treat patients independently. We often alternate visits between the oncologist and myself. We usually see them about every treatment to every other treatment during chemotherapy for symptom check-in and that sort of thing. But we have a really close relationship with our oncologist. And then the multidisciplinary approach, we work closely with the radiation oncologist, the surgical oncologist, palliative care, integrative medicine, all sorts of people. And then I have a wonderful nurse navigator that's on our team as well. So lots of roles.
Great. And we encourage our audience to learn more about all of those different roles that are available. One of the lectures that we did, I believe it was in the fall, was focusing on different areas of expertise. These were all ones that could be done with an associate's degree, and of course, many such as yourself go on to advanced degrees, but there are lots and lots of different pathways into oncology. I think in the interest of time, we'll go ahead and wrap up on the questions. I do want to go over a few other things. I want to let folks know that this series and all the series that we have are generously funded by the people of North Carolina through the University Cancer Research Fund and through the UNC Lineberger Comprehensive Cancer Center. We want to thank Veneranda Obore, John Powell, Oliver Marth, Andrew Dodgson, Nadja Brown, and Patrick Muscarella for all of their hard work for all of these lectures, including the one today. We do want to